So thanks again for asking me, and again for Gabriel for setting the topics. I'm a bit of a, this is really relation to IVC filters and the question of whether they're permanent or removable or whether they're required at all. It would occupy the mind, I think, of a lot of vascular physicians and surgeons, because if you're not a gatekeeper in treating these things, you all of a sudden, every man and his dog have got a filter placed in, both necessarily and unnecessarily. So trying to isolate who gets them and who needs them is actually quite a difficult role. And I think as vascular surgeons, we are at the forefront of making the appropriate decisions, mainly because we deal with the complications. So these are the filters that are available in Australia at the moment. There have been ones that have come and gone. The green filter we don't use anymore. In fact, I don't think I've ever seen one of those. But certainly a lot of the newer filters have got that basic design with IFUs suggesting of certain sizes for the IVC. It always interests me that people would be concerned about putting filters in the upper limb. I've never put a filter in the upper limb. I think that's a significant, there's complications are related to that. So most of these will go infrarenally, and that's probably the best place to put them. In fact, that's the only place to put them. So what's the evidence, or what is sort of the background relating to this? We do know that 40% of the proximal DVTs have evidence of a PE. 15% of patients who have a popliteal DVT also have evidence of PE. So when we get that situation and that call to see whether we can have a patient who has a filter placed, what are we considering? I mean, certainly there's that risk, but there's also a complication. And some places put up to 30 to 40% of the filters placed in some description will have some sort of complications, which is pretty high if you ask me. I think it's higher than would normally be the case, but complications can relate to anything from bruising in the groin to insertion, incorrect insertion location, or the devastating complication of having the patient's IVC thrombosed. The ironic component is that by putting an IVC filter in, there's a 3.3% incidence of new DVTs that develop. And when you get a thrombosed IVC, and for those of you who manage it, then we basically are looking at a patient who's got significant morbidity for the remainder of their life. The benefit of filters, though, after 12 days are there. Is certainly at a fourfold increase of PE rates compared to filter group in those patients that have had filters versus those that had without filter. So what we're saying is that those people that do have a filter placed in, it does reduce your rate of PE. The final group, the final thing we'd like to say is that patients often will get filters placed on the indication being of symptomatic PE. That's a worrying group because often we get requests to place filters in, and in patients where there's no evidence of DVT, should they have an IVC filter inserted at all? Well, ironically, there is some evidence to say that you will get some benefit, reduce your risk of PE, which makes me wonder that there's been inadequate imaging in the first place that does, in most situations, if it's properly done, will demonstrate that a DVT does exist. Just to reiterate what we've said, IVC filters will decrease the incidence of PEs, but they do also increase the risk of DVTs. There's reports from Blebler who reported that after filter insertion patients, there is a benefit even in those patients with no evidence of a DVT. Caval thrombosis, as indicated, has a significant morbidity. And then there's also complications in the newer filters in filter retrieval. including development of clot burden, embolization from the removal of the filter, and also patients who have had trauma related to wires and so forth in the walls of the veins. We've fished, for some of those who've been around, we've fished them out of right atriums, I've fished them out of jugulars, so they can all move, particularly the non-permanent ones. So as a sort of a general group, the indications for IVC filter insertion relate really to those who have an absolute contraindication to anticoagulation. All those patients who have any coagulation that's resulting, that will result once there's cessation, sorry, a thrombus that will result once already coagulation has ceased, and worryingly in those patients where there's been a failure of the anticoagulation. Most of the patients, most of the indications are summarised in the guidelines established by the British Committee for Standards in Haematology. Again, just to reiterate, those patients, those who have a thrombus with a contraindication to anticoagulation, those patients that have a PE despite anticoagulation, particularly pregnant patients, it can be a concern and should be considered. But more importantly, filters aren't recommended for unselected patients. So the presence of a DVT and the fact that they've got ongoing, a patient with a PE who hasn't commenced anticoagulation, that's not an indication. Free-floating thrombuses don't necessarily require IVC filtering, and the issue of thrombolysis we'll discuss a bit later, but those patients won't necessarily need to have IVC filter inserted. As we get into the filter insertion, we often get a lot of patients who require this filter to be inserted preoperatively, and this is just an example of what can happen. So this patient has an antiphospholipid syndrome, multiple DVTs, underwent a laparotomy. The surgeon requests a filter insertion. That procedure went very well. The filter was inserted in the correct position, but about 2 weeks later, after the procedure was required to remove the filter, you can see that the thing's moved out and jammed itself into the renal veins. Now, in this situation, this has now become a permanent filter. It's not going to change his management, but this is one of the issues, particularly when you decide to prophylactically insert a filter. In our hospital, the other issue is that often patients have filters inserted, and that's the last we ever see of them. There came a time with trauma patients in particular where they got a large filter insertion, and we've tried to follow up and found that only half the patients in our unit ended up getting their filters retrieved. That's probably because the population in trauma tend to be a lot younger, and once they're out of the hospital, they're gone for good. The other question really is when we've got those patients who we thrombolyse, whether we should use a venous filter, so IVC filter, particularly in thrombolysis. There's a bit of controversy as to whether we do this. In new patients who had PEs, there was an attempt through the Arizona group to look at this particular question, and it found that all PEs were in groups undergoing pharmacomechanical techniques rather than other techniques such as a period of long-term thrombolysis. So we're talking about those patients that underwent angiojet or penumbra type techniques, JEDI or Venturi type irrigation catheters that are aimed to remove the thrombus by agitating it. Essentially, the recommendation became a problem, and certainly in our YAN unit now, that if we're considering doing thrombolysis on proximal DVTs, we'll often do a CT venogram as well as a right heart assessment first, and that can be isolated on a CTPA. If there's evidence of clot of a high volume in the heart, then often in the pulmonary artery or the branches of, then what we'll do is we'll give them a period, we'll put the IVC filter in as well, and then try to use it that way. If there's no evidence of a PE and a clot, we usually don't use an IVC filter, but we can sometimes use a more gentle approach to dissolve the clot. There's no evidence at this stage, but I think it's something worthwhile. We do have some surgeons in our unit that will not consider filter in thrombolytic patients, but you can see what happens. This is a gentleman who presented with an occlusion of his left common iliac vein. We've got a large collateral, so we've been able to dissolve this clot. We did a CT and confirmed the presence of PEs. A filter was inserted, and this is on day 2 after the clot's been dissolved. The clot actually has migrated and been captured by the filter. This is at 6 weeks later. The angiogram shows that, in fact, the filter thrombus is now dissolved, which is unusual in itself, but I suppose it's the nature of the thrombotic event. The patient was then to have the filter successfully removed. And this is another situation where we've used the ECOS catheter. You can see the ECOS. Now, ECOS is a system where where the clot is, where the thrombolytic agent is under ultrasound control, pushed within the thrombus. In this patient, we use a filter again, but in a separate situation compared to the mechanical thrombectomy that we did on the previous patient. You can see there's no clot developed within the filter, and the filter was able to be removed on day 2 of the procedure. So in conclusions, IVC filters have their role. They certainly reduce symptomatic PEs in patients with an absolute indication for insertion. There is a chance of clot developing in those who have removable filters, but I would encourage every attempt made to remove a filter once it's inserted and to keep a close eye. I think it's, as vascular surgeons, we've got an obligation. If we make the decision to insert the filter, we should be responsible to have it removed. And finally, as discussed, the use of IVC filter, I think, is worthwhile in those patients that had a mechanical thrombolysis. Thank you.